Hello, everyone. A warm welcome to all. In this session, we will be discussing about what is palliative care, its importance, the misconceptions around it, and further topics. So I'm pleased to invite the faculty for the day, Ms. Smriti Rana, who is yeah, who is the head of strategic programs and partnership division at Pallium India. Her work focuses on ensuring safe access to opioid analgesics for pain relief in India by engaging with central government and other key stakeholders. She is the liaison officer between Pallium India's flagship clinical program, the Trivandrum Institute of Palliative Science, a WHO Collaborating Center for Training and Policy on Access to Pain Relief, and the WHO Southeast Asian Regional Office for Essential Drugs and Medicines. She leads capacity bridging programs for Pallium India through partnerships with other social development sector actors. She has been a spokesperson for civil society perspectives from LMIS on various platforms, including events hosted by the Vienna NGO Committee and UNODC, and was part of the experts group that developed the WHO technical report on globally applicable indicators to assess and monitor provision of palliative care services. Works for improved death literacy, appropriate end-of-life care, and for the inclusion of people with lived experiences at decision-making fora. She advocates the decolonizing healthcare and is passionate about the role of storytelling in humanizing healthcare delivery. She is the India Advocacy Focal Point for the International Association of Hospice and Palliative Care, and is a board member at the International Policy Consortium. Trained as a psychologist, Smriti began working in palliative care in 2001 after the losses of several family members in quick succession. I'm very pleased to invite the faculty for the day. Ms. Smriti Rana, over to you.
Thank you. Thanks, Rajika. Thank you, Senior, and welcome everybody. Welcome to the Pallium India series on the foundation course on palliative care. I'm just, I think there are people still coming in. So you're going to see a lot of me over the next few weeks. And over a period of time, you'll find that I will be requesting you every single time to turn on your cameras, even for a little bit in the beginning. We've all been through a lot of Zoom fatigue in the last few years. And what makes the Zoom fatigue worse is when you can't see each other's faces. So just for a few minutes, we won't do a full round of introductions because we don't really have that kind of time. But if you can just turn on your cameras so that we can always at least just have a quick look at each other, give each other a smile and a wave, and see your classmates for the next few series. All right. Always nicer when you can see everybody. I'm just going to wait a few minutes till everybody can do that. Sina, you might want to take a screenshot of our new batch.
Sure, ma'am.
All right. All right. So my name is Smriti, and I've been with Pallium India now for 10 years. And I have a I have some deep ties to the work from a personal point of view as well as from a professional point of view. And over the next few weeks, we are hoping to have an interactive session with all of you. This program, this particular foundation program was birthed from a felt need that people who are not, medically trained didn't really have anything to guide them when it came to, what palliative care meant for an interdisciplinary team. We talk about palliative care being an interdisciplinary service, but there's very little out there if you're not a nurse or a doctor for you to acquaint yourself with the field. So this was our offering to you, that hopefully by the end of these few sessions, you will have a more robust understanding of what palliative care is, the different ways in which you can engage in the field if you're not already a part of it. And if you are already a palliative care practitioner, then hopefully this series will give you new ideas, and maybe we can end up collaborating on a few projects as well. Okay, so I have gone through the list of our participants, and I have to say that I'm really I'm quite taken by the fact that it's a very varied group. We have art therapists, we have social workers, we have CEOs and administrators, we have nurses, doctors, dietitians, massage therapists, researchers. Wow. So it's a really, really diverse group. So that means all of us are bringing different things to the table. And how this is going to go is that I'm going to encourage you to use the chat box and ask questions in the chat box. If you have an observation or a comment, please leave it in the chat box. From time to time, I'm going to ask you for an opinion, which you can put in the chat box. I will request, just to maintain hygiene, that, you know, because palliative care is the kind of field it is, and almost every one of us has been touched by illness or caregiving or an experience of bereavement, things might come up in the course of this series. Let's save any personal sharing till the end of the class, because when somebody shares something very personal and deep, it's not possible for us to move on from there very quickly. And that might take up some of the time, and we may not end up actually finishing the elements of the class. So, but we do want to hear personal stories. We'll try and save, you know, a few minutes at the end of every session once we finish the Q&A, and we'll even stay back for a few extra minutes if people feel moved enough to share something which is very important to them. Okay, so I'm going to get started. And actually one last thing before we start. Can you either unmute or put in the chat box one word right now to describe your current state of mind? It could be an emotional state, or it could be like a cognitive state, or it could be a physical state. I would prefer it to be as close to your mental state as possible, just to get a read on the room. Curious, thank you, all right. I like that, motivated. Okay, there's a lot of curiosity. There's 34 people in the room, so let's, okay. Keep them coming. So that's good. That's good to, there was going to be somebody who's exhausted for sure. All of you are in, a lot of you are in healthcare. So I imagine that, you know, this time of the day is not an easy time of the day, especially if we've had a big lunch. And here, what we're going to try and do is we're going to keep breaking from time to time, just to get you to even perhaps stretch a little bit and move around a little bit, because it's not easy to sit for 1.5 hours straight. Okay. By and large, though, we're starting off on a positive note, and I like the look of that. So let me get to my slides. Senior, can you let me know if the slides are visible, please?
Yes, ma'am. Clear.
Fantastic. Okay. So before we talk about palliative care, we're going to have to talk about healthcare, because of course palliative care is a part of healthcare, but where in healthcare are we trying to fit palliative care in? One of our stated missions in Pallium India is to integrate palliative care with the larger, with mainstream healthcare. And why is there a need to do that? Why is palliative care not already a part of healthcare, that we have to put the might of our entire organization behind this to say, no, palliative care must be a part of healthcare? Why is that not already the case? So according to WHO, health is not only the absence of disease and infirmity, it is also the presence of physical, social, and mental well-being. Health is not only the absence of disease or infirmity, it is the presence of physical, social, and mental well-being. So if we go by this it's a nice definition. If we go by this definition of healthcare, let me ask the room right now. Are we practicing healthcare at the moment? In your experience? Is what we're seeing around us true healthcare? Or are we just focusing on diagnosing and treatment and cure? If you've had an experience where you think that this is being practiced, I'd love to hear that. But in your experience, maybe not even as a healthcare professional, let me ask you as a layperson who has probably looked after somebody, or a person who's been through an illness, Has your experience shown you that healthcare is focusing on the second half of that statement, which is it is the presence of physical, social, and mental well-being? How many times has that been taken into account, and how many times has it only been about the disease? You see limited palliative care departments in hospital. Okay. So I can see that a lot of people are saying no. I'm hoping that the room will warm up a little bit more and people will get more interactive. But I'm just going to go with the fact that so far amongst the people who've answered, people don't believe that healthcare is truly being practiced in the way that we're talking about it in this slide. Okay. So India's healthcare at the moment is one of the most unsatisfactory in the world. This is a slightly dated statistic, but I don't think we've moved very far up the ladder. And we are even behind some of our less resourced neighbors. That's something that should give us pause. A country that is supposed to be on the road to development. Why is it that our healthcare is so poor? So the other really startling statistic, and this is a 2014 statistic, we've got the 2021 statistics. The numbers haven't changed a lot, which is basically, according to the National Crime Records Bureau of India, approximately 1 in 5 suicides in this country happens amongst people who have a chronic or a serious illness. 1 in 5 people who choose to end their lives is a person living with a serious illness. Why would someone who is seriously ill choose to end their own lives? Any guesses? Any thoughts on this? I see from...
Hi, ma'am.
Yes, please go ahead.
This is Nancy. First of all, thank you for letting me be part of this whole session. And as an answer to your question, I believe that when people are undergoing a serious illness, they lose a sense of purpose in their life. Life stops becoming meaningful for them, and at that point, death looks more an act choice than life itself. So that is why they would probably end their life.
And why does life seem so bad?
Because the serious illness, they're not able to cope up with the serious illness, either because they don't have that kind of social support or the kind of medication or medical support that is required to get the best results out of the condition. And due to all such absence in their life, they lose hope. They believe that things cannot get better, but it'll only get worse over time.
Okay. Thank you, Lindsay. Thank you. That's a very, those are very pertinent points. And it's, lack of support, the suffering that the person is going through, sometimes it might seem like it's a better option to end their own lives. I'm also just going to quickly check in with the chat box. Anxiety. Oh, and thank you, Vivek and Rajesh, for your comments earlier. Okay, anxiety of nearing death, focus on the illness, not on their life. Excellent point. They feel hopeless. Social stigma attached with chronic disease, financial commitments, acid attack patients. Okay, that's also because of disfigurement and clinical depression, being unattended, emotional. I don't think I have to teach much in this class, Inya. Seems like everyone is on the ball. All right. Terminal illnesses can also be a huge financial burden on families, and people may see suicide as a better, easy way out for their families. They think it's heavy on the ones they live or are around. Okay, my job is half done. All these points are absolutely essential. And while there is no actual study that draws a direct link between the number of suicides amongst seriously ill people and all of these statements that you have shared, it doesn't take a lot of application of the mind to understand that these are all related. We've all experienced it. And fear of pain, uncontrolled suffering, uncontrolled symptom, uncontrolled distress symptoms. And like somebody said, the financial burden, you see yourself as a burden on the family. Now, all of these things are absolutely true. And here are some more statistics. Unfortunately, the first half of this session is going to be just full of more and more depressing statistics before we actually get to the subject matter on hand. End of life care in India. This is a statement by Dr. Sankar Mitra, who was with us in Palliative India for several years. He was on our board. The poor die in misery, in neglect. The middle class die in misery, in ignorance, and the rich die in misery on ventilators. And no one gets a pain-free and dignified death. Okay, so there are exceptions to the rule, of course, but just for the sake of like rhetoric, we are going to say that yes, this is the scenario for everybody. And there's another really, a friend of ours who you will be meeting, Dr. Roop Gursahani, who leads appropriate end-of-life care, the appropriate end-of-life care movement in India. He talks about how modern day, and he's a neurologist, he's a consulting neurologist with Hinduja. He was involved in the Aruna Shanbag case. And he says, modern day hospitals sometimes are like fortresses. The rich can't get out and the poor can't get in. And that seems to be that seems to be the case. That seems to be the reality of the situation for most of us. So the end of life care in India is so bad that as per the 2015 and the 2021 Quality of Death Index, this is a study that was commissioned by the Lien Foundation. It was run by the Economist Intelligence Unit. And it had several parameters. So what are these parameters? Human resource, medicine, support, social support, training of teams in palliative care. There are several indicators that went into the study. And based on all these parameters, India in 2015 ranked 67 out of 80. And in 2021, we were 59 out of 81. So we didn't climb very far up. And if you look at this chart, I don't know if it's clear to all of you, but you'll see that the majority of the countries on top are all first world countries, countries that we call the global north. And if you look at the countries at the bottom, we're all global south countries, developing countries. Okay, and we're going to be talking about that in a little while. So I want you to just park that thought for a minute. So according to the Quality of Death Index, we are ranking very badly. And the impact of healthcare, this is another study that came out in 2017 and was published in the Lancet in 2018. Catastrophic out-of-pocket health expenditure pushes 55 million Indians below the poverty line annually. That's 55 million Indians being impoverished as a result of healthcare expenditure, of which 38 million Indians are pushed below the poverty line because of the cost of medicine. Now, consider this for a moment, the kind of healthcare service that we have, not service, I won't call it a service, the healthcare system that we have at the moment, the way it is currently functioning as per evidence is that it inflicts more suffering on people who are already at a vulnerable time in their lives. By virtue of, it's the nature of the beast, when you are sick, you enter a healthcare system when you are already vulnerable, you already have an illness, you are already at a lower, you're already functioning less than optimal. And there is an implicit hierarchy that you enter. I mean, whether we obviously state it or not, there is a power dynamic once you come into a healthcare system. There is the doctor, there are the administrators, there are the people who decide what the packages are, there are the insurance agencies, there's all of that, the targets, the medical representation and all of those things. And all of that comes way before the patient and the family's needs. So this is currently how it is set up. I'm not here to, to offend or disrespect all those people who are actually committed and in this field. But this is just a description of the larger gaps in the system. So I'd like to be very clear about that. I'm not here to criticize every aspect of healthcare. I work in healthcare myself, but these are some very harsh realities that we have to pay attention. Now, some of you might be familiar with the whole universal health coverage concept. And universal health coverage is part of the Sustainable Development Goals of the world, the SDGs. And in Astana, which is the capital city of Kazakhstan, in 2018, there was something called the Astana Declaration, where countries from around the world got together and they declared that under the universal health coverage package, quality healthcare should reach people where they are, when they need it, at an affordable cost. I've highlighted some words in red. Quality, okay? So it has to be of good quality. It can't be some rubbish. Should reach people where they are, when they need it, at an affordable cost. So you're talking about quality, timeliness, coverage, and affordability and accessibility. And this sounds very utopian because I mean, we're far from this at the moment. And it also goes on to say that health for all has to be health with all. And we have to include people in designing and controlling health systems. So what they're saying is it cannot be just a top-down approach where some policymaker sits here and decides what's good for some rural village in Chhattisgarh or in another part of the country. It has to be in line with the values, preferences, needs of the communities that they serve. And so for that, you need people from the community to be part of designing this healthcare system. Okay, so here's a story about a man called Butaya, who in 2016, the story came out. Some of you might remember the story. It came out in the Hindu, and it basically talked about this man who had moved a lower court seeking to euthanize his 4-year-old son. And of course, the court said no, because euthanasia is illegal in our country. And if we want to talk about that a little later, we can talk about it. We have some new end-of-life care, directions that have come out of the Supreme Court. But euthanasia is illegal. And so this boy who had cancer was in so much pain. The family, so when we heard about it, several palliative care organizations and experts from South India, we got together and we tried to track this family down. And we found that the trail ran from Hyderabad to Madras, to Bangalore, to Visakhapatnam. They had been to as many big cities as possible. And the sad thing is in Hyderabad, they had gone to a hospital that was literally a stone's throw away from one of the best pediatric palliative care hospitals in the country, run by Dr. Gayatri Palat. And the child wasn't referred there. And finally, when the family was found, they were in ICU in Bangalore. A social worker went on an overnight bus from Hyderabad to Bangalore, carrying immediate release oral morphine for this child so that this child could get some pain relief. And that social worker was not allowed to meet the child. And the child died in excruciating pain, also leaving behind a debt of 15 lakhs that the family now had to pay off after losing their child. So why am I telling you all these depressing stories and facts? I mean, surely there must be a point to it, right? It's because this is the current state of affairs. And this goes back to why is it that people want to end their lives? There is intractable suffering. There is no pain relief. And the healthcare system is impoverishing families. So of course, like Nancy said, sometimes the better option is to just end it. Now, here's where palliative care comes in. So why palliative? Actually, the question should be why palliative care instead of what is palliative care. But let's, for the sake of those of us who are new to palliative care, let's talk about what palliative care is. And maybe you'll find that the why to the question is in the what. Okay. Now, before we go into that, here are some myths that, over the years, we constantly hear this from people. Palliative care is only for people dying of cancer. True or false?
False.
False. Okay.
False.
Yeah. Palliative care can benefit patients and their families also from the time of diagnosis of any life-limiting or life-threatening condition.
True.
True.
All right.
True.
And just to be sure that I want to be very clear about this life-limiting versus life-threatening. Okay? Life-threatening, of course, is a terminal diagnosis. Life-limiting is a condition that, because of the way things are constructed around us, it could be someone living with a disability.
False.
Okay, all right. I think we're having a bit of a lag. Okay, so palliative care for life-limiting conditions. So I was describing life-limiting, what the word life-limiting means. It means having a condition that doesn't allow you to fully engage with life. And not because you can't, it's because, for somebody in a wheelchair, for instance, we haven't made the place accessible. And that limits them to a particular place unless they have help. So we have had people in our program who've been in our palliative care program for over 10 years. So it's not only for people who are at the end of their lives. It is not only for people with cancer. It is for anyone with a life-limiting or a life-threatening condition. Okay. Palliative care means giving up and there is no more hope for me. And this is something that we hear often. People are like, no, I'm not ready for palliative care. I still want to try the third line, fourth line, whatever. And this is the myth that has been propagated and perpetuated, that palliative care comes at the end and basically means that there is nothing more that can be done. Now, the reality is that what we are talking about in palliative care is not giving up, but not going down a path where there's only futile interventions. A fourth stage, fourth grade cancer, or, someone who's 75, 80 years old with fourth grade, fourth stage cancer, going for chemotherapy and surgery and then ICU admissions, it's futile after a point, because the suffering that comes as an outcome of the treatment it does not justify it. It does not justify the treatment. And so what we work in palliative care to do is look for treatments. Of course, you can have palliative care even while you're undergoing curative treatment. There is also palliative chemotherapy. There is also palliative radiation. So it's not to say that the two are separate from one another. And the focus is not about intervention after intervention. It is about quality of life. And if a surgery can offer you a better quality of life, by all means. If a particular drug regimen can give you a better quality of life, by all means. But let's not do the futile stuff that only adds more suffering, not just in terms of the physical distress that the patient feels, but also the financial distress that it brings with it. A lot of people believe that palliative care hastens death, which is false. Good palliative care provides comfort and best quality of life, no matter how much time is left. And there are actually studies out there that will tell you that good quality palliative care actually, in some cases, has shown to contribute to the extension of life. People live better and they exceed their life expectancy. Pain is a part of serious illness and dying. So if you have cancer, then pain is natural. And this is really, I think to me, this is one of the saddest, assumptions, because even as till about 2019, yes, there are elements of pain management, pain relief in the medical undergraduate curriculum. But for the most part, it's a non-examinable subject, which means a medical student, it's there in the textbook, but you're not tested on it. If you're going to study medicine for 5 years, are you going to really pay a lot of attention to a subject that is not even given the importance enough to be questioned in a question paper? So essentially, the way the undergraduate medical curriculum was framed gave you the impression that pain relief is not a priority. So, it was really not something that was given a lot of importance. And that actually has contributed to a huge number of medical professionals coming out not knowing how to manage pain properly, or worse, saying this, it's part of the process. You've got to just bear it. And the truth is, it does not have to be a part of illness and dying, and we have many ways in which we can alleviate pain. And by pain, I don't just mean physical pain, and we're going to talk about this in just a few minutes. Okay. Some people believe that morphine is administered to hasten death, and this is a very, very pervasive myth. That if you give morphine to somebody, it is going to kill them faster. And that is absolutely not true, because appropriate doses of morphine can keep patients comfortable, and it does not hasten death. I've been caregiver several times in my life, and I'm not averse to sharing some of these things where I hope I can drive a point home. I took care of someone who's very, very dear to me when I was a teenager, who had cancer, and there was absolutely no pain management. And she died in excruciating pain. She died in excruciating pain. As recently as 1 month ago, I took care of my mother, who was given morphine for her chronic breathlessness. and the morphine really alleviated her breathlessness. So morphine is not just for pain; it has a huge role in breathlessness. And the difference was that I didn't have access to it for pain relief 23 years ago. I had access to it with a lot of difficulty for breathlessness at this time. And I was asked this question: why are you giving morphine to someone who's not in pain? And I had to constantly, um, you know, hopefully politely justify the use of morphine in this. So this is a myth that has been around for so long that we really need to advocate to get rid of it, because it's not true. And what it does is it becomes a deterrent for pain relief and for the relief of breathlessness for a lot of patients who would really do much better had they got access to it. Taking pain medication and palliative care leads to addiction. This is a big one. And I hear a lot of attending doctors say to families who, eventually we get to talk to, saying that, my mother's in a lot of pain. Please, can we start her on, isn't there something stronger? Can we not give her morphine? And the answer comes back, we are not there yet. And my question to you is, how much suffering must a person endure before they become entitled or before they become eligible for pain relief? And the truth is, appropriate doses of morphine and other opioids administered by trained professionals does not lead to addiction. And we have a lot of evidence for that. We've done studies. There's evidence for safe use of morphine over a long period of time for people. And there is no evidence that it has been misused or it has caused any addiction. So these are some of the major myths that we're going to keep trying to bust as we go along. And now that all of you are invested in palliative care, I hope that you will, join this movement to really get rid of all these myths. I'm just going to take a second to check in with the. Okay. All right. Now, this is one description of palliative care. It is the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life of patients, their families, and their caregivers. This is a big mouthful of a definition, so I'm not going to expect anyone to be able to say it back. I can't say it back, but you get the gist, right? It's for everybody. It's across all disease spectrums, and it does get enhanced towards the end of life. There's more of a role for it, but it can be started at diagnosis. Okay. This is another way of looking at it. There's a life-limiting illness, there's a terminal illness, there's pre-active dying, and there's active dying. Active dying is when the person's systems are shutting down, and there's that things like the gurgling, death rattle. Pre-active dying is when the person gets weaker and weaker, they get withdrawn and things like that. Certain symptoms flare up, certain symptoms get exacerbated. So this is another way of looking at it. I'm not going to go through the slide in great detail. You will have access to my PowerPoint later, so you can spend some time looking at all the different aspects here. Maximizing quality of life, which also involves chemotherapy, palliative radiation. There could be palliative surgery. There are lots of different things in this outer circle that are still options. And towards end of life care, what becomes more important? Psychosocial support, spiritual health care, symptom management, etc. And what happens during terminal care. Okay. Now, recently, some of us got together and, we said there are so many different ways of looking at palliative care. So we created a little graphic that meant the most to us. And this is what it is. A lot of people perceive palliative care to be end of life care. But what is palliative care really? It's so much more. And community support is a huge part of palliative care. It's an interdisciplinary approach. Pain relief and symptom management are a huge part of it, but they're not the only part of it. And for true palliative care, you have to provide psychosocial and spiritual support. There's sort of death preparedness when in certain cases where there is a terminal illness, death preparedness for the patient, for the family, for other members of the community. Family and caregiver support is a huge part of palliative care, because it's not just the index patient that we look into, but we look at the care of the entire family unit. And we really believe that the the disease that impacts the disease diagnosis of one person in the family has a huge impact on the entire family and for generations to come. Now, this catastrophic healthcare expenditure, for instance, we know of people who have just the illness of one person has caused multi-generational debt and impoverishment. People have been pulled out of, children have been pulled out of school so that tuition fee can go towards treatment cost. People have given up their jobs to become caregivers. And so the impact is really far reaching. It's not just the disease, the cancer, the renal disease of one patient. It is how it impacts everybody. And that's what we call serious health related suffering. Serious health related suffering means that one person's disease has serious consequences in different ways. There's financial suffering, there's spiritual suffering, there's social suffering. And so if we are practicing true palliative care, then we have to look at all of those different things together. And restoration of dignity. One of the biggest collateral damage when someone is sick is their dignity, because suddenly they're not a person anymore, they're a case number. And even the caregiver is not a person anymore. They become this, there's this word that I personally absolutely despise, which is bystander, which I would really, if I could eradicate that word from the vocabulary of healthcare, I would do it, because bystander means someone who stands by and does nothing, when a caregiver is really somebody who does all the heavy lifting. So I find that the word bystander is very demeaning. And a lot of people who come to us for palliative care, they've never been asked, the caregivers have never been asked their names. And there is something that destroys the dignity of a person when they're just seen as a case sheet. And palliative care is about restoring that dignity, finding out what is the story that this person has. Who is this person? What is important to this person? And how can we support this person in a way that will bring the sense of dignity back, even if he's lying in bed and has to use a bedpan, he still has a sense of dignity that we need to restore to this person. And empathetic communication is here, it's the sky, because it shines on everything. Whether you are a doctor providing pain relief, whether you're a community member, whether you're a counselor, empathetic communication has to go through every single aspect of your service delivery. And so that is a gold standard. Okay. All right. We have this concept of total pain. And the more sort of prosaic definition is what is on your screen at the moment. When a patient reports their subjective pain on the pain scale, just to familiarize some of you, is 1 to 10. 10 is unbearable pain, 0 is nothing, 1 is manageable pain. I mean, it gets higher, going up to 10. And in palliative care, we ask people to tell us, where are you on the pain scale? And they'll say 4, 5, 6, 7, depending on how they feel. But what we're saying is that it is important to remember that the physical pain reported by a patient is compounded by their current life circumstances. So let's just do this little thought experiment, shall we? Can screens be turned on for a minute, please? Those who can, if you have bandwidth. If you don't have bandwidth, that's absolutely fine. Don't worry about it. But if you can, let's have more faces on the screen. And feel free to use the chat box. Okay, so here's a scenario I want you to imagine. All of you who are working in all these different sectors, I can imagine that you have good days and bad days. And let's imagine that it's hopefully you have Sundays off, or at least one day of the week off. So whatever day of the week that is, let's imagine it's that day where you are not at work, you're at home, and sometime after breakfast, you find that you have this headache. Okay. And it's a regular sort of headache. But hey, it's a Sunday or whichever day of the week you have off. And so you are at home, you decide to go lie down. Somebody makes you a hot cup of tea or soup. Somebody else comes and gives you a little bit of a head massage. You can take a nap. Maybe it's a hot day, so you can, lie under the fan. So given all of those things, where would you rate that headache on a scale of 1 to 10? It's a regular sort of headache that, it's not a migraine, it's just a headache. 3, 1, 2, 2, 5, 2, 4. All right. Same headache, nothing has changed in terms of its physicality. Same headache. Maybe for some of you, you feel it throbbing behind your eyes. For some of you, it's one side. Some of you, it's here. Whatever. Same headache. Yes, Rajesh, that is a luxury. Same headache. Monday morning, you are behind on deadlines. You've had a big fight with somebody at home, a spouse or a parent. Your child won't stop crying. He's got a bad stomach. You have to figure out whether the child is going to school or not. You haven't completed an assignment that you're supposed to complete, and you're on your way to work, and you have a flat tire, and it starts to rain. Same headache. What would you score it now? I like the 11. Okay. Okay, so where's the score now? 10 plus. Normal headache is still 0 and 10. Yeah, but the circumstances have changed. How are you experiencing the headache now? Yeah. Okay, so we're not getting into the technicalities of what kind of neuropathic pain it is or whatever. I'm talking about the fact that you are in pain. Okay. Or forget that it's a headache. Maybe it's a stomachache. All right. Or maybe, like people who've had a bad stomach and you're at home, you have the toilet next to you. You can use it whenever you want. Same bad stomach, you have to travel. It feels different. Okay. So this is the thing, that the experience of pain will change depending on circumstance, whether it's pain or distress, whatever it is. And this is just a simple example. It's a very trivialized, distilled down example. We didn't even really go into the full sensorium experience of this. But it's easy to imagine that the pain does feel different when circumstances are different. Okay. So similarly, for somebody who is going through a severe illness crisis, who has to mortgage their house to pay their bills to get treatment, someone who has to, leave the job that they really love to be at home, someone who's lost an opportunity to pursue a career in a different city because now they have to take care of somebody who's sick. All of these things. And the burden that the patient might feel that, oh my God, my family is making all these sacrifices and I'm the reason for it. So, or sometimes the patient is not supported emotionally. Okay. So all of this can make things feel much, much worse. And so when you're talking to somebody and asking them, where are you on the pain scale? You will find that their pain, their physical experience is determined by what has happened around them. And we've had some experiences where if you take care of some of those problems, their pain scale comes down. And we have an example of this. We went to a fisherman's house one day, and this was when I was very young in my career in palliative care. And I had accompanied Dr. Raj and a team, and we met, this guy who was screaming in pain. And when we went inside, his house it smelled really bad. And he just had his wife who was completely, she didn't know how to look after him. She only kept feeding him. And after a while, because he had a bowel obstruction, this man was vomiting his own waste. And at the time, his pain was 9 on 10. And he was cleaned up, he was given all kinds of, he was given morphine, he was given all of that, but his pain would not go below 6. It just wouldn't go below 6. And after a while, this man was asked, like Dr. Raj asked him, he said, what's your biggest concern at the moment? And I remember as a young in the field thinking, it's quite obvious what's bothering him. And this man was very quiet for a while. And after a while, which to me was a lifetime, I would have just been so awkward with that silence, I would have said something. But Dr. Raj actually kept quiet. And after some time, I would say it was 5-6 minutes, this guy says, all I wanted was for my children not to be fishermen. So he knew he was dying. He knew that his wife was not educated. And now his children are going to have to drop out of school. and they're going to become fishermen like him. So we have an education support program, and normally it takes a bit of time, but then here what we did do was we sped things up, and these two children, their education was sponsored right up to college, and this was all done in a couple of days. We went back to visit this fisherman, and he was still at 6 on the pain scale. He was given this news that his children would get their education. We sat with him while he understood what that meant. And then he was asked, where are you on the pain scale? And he said 1. So it was the fact that the stress around his children was actually making his entire experience much worse. And he actually died 3-4 days later. And we were actually able to manage his pain beautifully after that, because he did respond to it. So these might seem like extreme stories, but they're not. We see them on a regular basis. And those of you who are working in palliative care are familiar with these kind of scenarios and stories, I'm sure of it. Okay, so coming back to total pain. I think we've belabored the point enough now. And total pain really takes into consideration a person's physical distress, psychological distress, how it has affected the family socio-economically as well as spiritually. So my job as a palliative care professional is not just to handle the physical distress, but to see where else I can reduce the suffering. Now, so that's where counselors come in, that's where social workers come in, that's where nurses and volunteers and everybody else comes in, because everybody as an interdisciplinary team will take on the responsibility of, okay, we can't take all the suffering away, but let's see what we can do to help this person or this family cope better. Okay. Now I'm just gonna, Senior, you're gonna have to help me out here because I always mess up the audio. So I'm gonna pull up a video for you. This is more of a Western video. It's a Western approach, but I also like the way it described palliative care. So Senior, will you give me a thumbs up when the sound also comes on, please? Yeah.
Yes, ma'am.
So that have to be to see your screen. Turn way of palliative care, and okay. So it's going to move on from there. Now, why palliative care? Okay, I think we've sort of talked about what it is, but already why palliative care is important has come into the conversation. Now, here is the usual model where you have healthcare and you have the individual, and there are several barriers that a person needs to be able to cross in order to access the appropriate kind of healthcare that he or she or they need. Okay, now what is appropriate for one person may not be appropriate for somebody else. There is no template or one size fits all in healthcare. Very often, I mean, you will also, I think at some point, I hope you will encounter Dr. Aju Matthew, who is an oncologist, who says he does what is called a needle, not called a wallet biopsy, because someone comes to him for treatment. He also has to see whether they can afford this treatment over a sustainable period of time. I can't, and you can't prescribe medication that the family can afford only once when it's needed 8 times. And in order to afford it 8 times, somebody in the family has to go hungry. There is somebody else who can afford it. So there are several different, things at play. And very often it's this individual or this family trying to navigate this maze of healthcare to finally arrive at the macro tertiary hospital and get the kind of care they need in a way that is affordable to them. And the other thing is that there is this distance because healthcare providers cannot be everywhere. No matter what universal health coverage aspires to, a doctor who is doing so many hours in the hospital, goes to an outpatient clinic, is a consultant somewhere else, or a nurse who's pulling long shifts, you can't then go into the community and practice. And you have community people, you have community-based healthcare as well, but everybody cannot be everywhere all the time. And so how do we bridge this gap where this person cannot get in and this team cannot get to that person? This is where the Kerala palliative care model has been talked about quite a bit, where we really have leveraged what we call the social capital. The people in the community become the bridge. Okay. And how does this happen? So I'm just going to take you through a series of pictures. We have what we call our link centers. Now, a link center is any public place in a village or in a panchayat, in a vicinity, and that could be in this picture. It's a primary school. It could be a library. It could be a community hall. And what happens is that we have patients who are registered from that particular community with us, and we have home care teams that go out, 5 days a week into these different parts of Trivandrum, and they go to this link center. Now, families and patients who are able to come to the link center to get their medication and to be seen, they do that. But the sickest of the families, the sickest of the patients cannot come here. So what happens is that home care teams then go into the homes of those families. There is a volunteer training system where the volunteers in the community will sign up to do a few days long volunteer training with us. And they are then equipped to identify when someone in their community could benefit from palliative care, whether it's a bed-bound patient, an elderly woman living alone, somebody who's recently been in a road accident, a child with a congenital anomaly, and a single mother. So these are people who would benefit from palliative care. So they come back and they sort of make a note of it at the link center, so that the next time the team comes there, the community says, hey, there's one more person that we want you to come and see. And then we go there and that person gets registered with us. So really what we're seeing is that the community becomes our hands and eyes and ears. And they're the ones who know their communities best. And they will take us to the people who cannot come to the healthcare system. And this is what home care looks like very often, through very rugged terrain, roads that are not motorable, again, not accessible to patients. Ambulances cannot really get to a lot of these places. And you have an interdisciplinary team that goes to these houses. Very often houses are, this is actually compared to some of the houses I've seen, this is actually quite comfortable. But we visit them in their homes, and the entire interdisciplinary team meets with different members of the family and attends to whatever the needs of the patient are. And so here's a story that I want to tell you. This boy that you see in the orange lungi, at the age of 19, he had been in a road accident and he had lost the use of his limbs, and he had a head injury as well. And he was advised to go to the hospital every week to get physiotherapy. Pretty straightforward, no? Go to the hospital, get physiotherapy once a week, you should be better soon. Now, here's the problem. He was the son of a single mother who worked in a factory or a tea plantation, one of them. She was much smaller built than him. To take him to the hospital meant, first of all, the house was on a little hill, over another hill, and the nearest road was about 1 kilometer away. To get him to the hospital, 4 men from the village would need to take a few hours off work, put him on a khatia or a stretcher of some sort, carry him very carefully over this terrain, 1 kilometer away, where there was no bus stand. And the lady had to hire an auto rickshaw, take her son to the hospital, make the auto rickshaw wait, and bring him back, which was 2 weeks' salary gone. So did this boy get to go to physiotherapy every week? No. So when home care found him finally, he started getting physiotherapy at home. We did what in Dartmouth University they call reverse innovation, which is basically using the most, in resource poor settings, using, jugadi stuff to have the end result, the same outcome. And in this case, we put two bars of wood, tied it up from one window to the next. That became his parallel bars. And after 3 years, I'm very pleased to tell you that this boy can support himself and he can walk. What would have happened to him had this home care team not found him? What would have happened to this boy had this home care team not found him? It's a question I'm asking. What is likely to have happened?
He would have gotten worse.
Physically and mentally, he was already very depressed when we found him. So this is it. You don't, and so very often, and this, there is an advantage to also, I'm not saying that this is possible. Yeah, he would have probably thought of ending his life. There's a good chance he would have thought of it. Now, this is the thing, not everybody can be everywhere all at once, but this is where you need to bring the community, and so they can help you reach the people who need your care. And the thing is that visiting somebody in their home really gives us a sense of what is possible and what is not. To say, here, one strip of, whatever medication twice a day, you have to have a tablet twice a day for the next 3 weeks or whatever it might be. How close is the pharmacy? If the patient is an elderly person living alone, how are they going to go and collect the medication? And it's very difficult to really assess all of this. But when you go home care, it starts to become, I think we become a little bit more empathetic in what we're prescribing. Okay. What is the point of all the free medication and interventions when the family is so poor that they have nothing to eat? About 100 families are in our care and are getting free food rations because that is also the mitigation of suffering and serious health-related suffering, because the family was likely impoverished by the impact of the disease. Something can be available but not accessible because it's just impossible to get there. But then, I really think that some of these are, to me, heroes and heroines, because this is the kind of terrain that is being navigated to get people the care they need. And imagine if a able-bodied, fit nurse is having this much difficulty climbing down those stairs, no patient is going to be able to navigate that if they have a serious illness. Livelihoods are lost when people have serious illnesses. So very often vocational rehabilitation becomes important. The gentleman on the right of your screen, these are all pictures with consent, just for your information. The gentleman on the right of your screen is making an umbrella. He has had paraplegia for several years now and was out of the workforce. And part of the loss of dignity is not being able to contribute to the coffers of your own family when you used to be the breadwinner. So giving options that they themselves choose, okay, whether somebody wants to become a seamstress or whether somebody wants to start making umbrellas, but just to be employed and to contribute to the family's income is a great way to restore their sense of autonomy and dignity. And that is also palliative care. Children are oftentimes invisible patients. We think children don't understand, but they do understand their illnesses in their own ways. And working with them to make sure that they have enrichment, not just treatment, is really important. There is, child life enhancement that needs to be done. And very often, yes, children may be scared of needles and things, but they still need to play. Children need to be able to play. They need to be able to express their feelings. They need to, draw and have art and all of those things. So that is also a part of the children's palliative care program. One of the biggest collateral damages to families is the loss of educational opportunities, because children, like I said, are pulled out of school in order to reallocate that money for treatment cost. And so, like that fisherman, it can alter the course of a family's future. And so providing educational support is something also that we do, where at the moment we have over 400 children who we have provided educational support to. And I'm very, very proud of the fact that several of them have gone on to study medicine and are now coming back to contribute to healthcare in India. And India has a huge number of elderly people, especially women living alone. Kerala alone, I think a 2011 statistic was that Kerala alone had 146,000 women living alone, elderly women living alone. And that comes with a whole bunch of other, compounded issues. Because what happens if there's a fall? What happens if they've run out of medication? What happens when during the pandemic, when they need their parameters checked and there's nobody to help them with that? So these are things that we need to also pay attention to. Now, I'm just going to stop for a few minutes here. It's 4 o'clock, and then we'll just, I want to take a quick read of the room. We'll just take a couple of minutes. The next section is about advocacy, but I just want to stop and take any questions that people might have, or any reflections or any observations that you might want to share with us, with the rest of the group. And if you want to turn your cameras on, that would be. Post-lunch silence is always very ominous. No questions? Any experiences that anyone wants to share from your own practice?
Ma'am, Mansi have raised her hand.
Please go ahead, Mansi.
Hi, Smriti. So I'm from Mumbai, and I run this organization called Happy Feet Home. We met a couple of years ago. Smriti, I wanted to just check, basically everything that we've spoken here, everything that you took us through is what we try and do at Happy Feet Home too. My concern is just, the regular idea that people in hospitals have. Like the moment I used to work with another organization which took care of children living with cancer, and the moment they were declared palliative, they knew that they're going to die. And that's what the hospital would also convey. Like, you don't have enough time, you rather go home, die with your family around you. And palliative care department was basically when the medicine's not going to work and you have to go home. Now that is where your biggest population goes, right? And how do we ensure that this doesn't happen?
Thank you for raising that point, because I think that's one of the most serious barriers today, the lack of referral in time. And this idea, and why does palliative care become this last ditch effort, or this last, where people go to die, is because the referrals happen so late. There's no rule that says that palliative care can only come in after curative treatment has failed. But the problem is that the referrals don't happen till such a time when the doctor would say, there's nothing more we can do. And then it becomes this, there's nothing more we can do, therefore, be carted off to the palliative care department. The solution is not an easy one, because it's not a quick fix. We have a whole mindset to change, and unfortunately, it's amongst our own medical fraternity. If it has not been part of the medical undergraduate curriculum till 2019, you can imagine the work we have cut out for us. In 2019, the Medical Council of India, which is now the National Medical whatever it is commission, has decided that, okay, attitude, ethics, communication, pain relief, end of life care has to become a mandatory part of an undergraduate medical students' education. 2019.
2019, I know.
And then the pandemic hit. Now, great, it's there now in the curriculum. Who's going to teach it? Because every single palliative care expert in the country today is working at full stretch. All the palliative care physicians and nurses and teams that I know. And yet our coverage is less than 4% of India. There is one palliative care doctor per million people in this country, if you go by some statistics. Wow. So you have to be
that's appalling.
It's appalling. And so you have to be the service provider, you have to be the teacher, you have to be the person who's also doing policy advocacy. Where do you have time? Exactly. So here's the thing. So actually efforts are on, Mansi, where we are working on a training of trainers. All your government medical colleges, where now this is part of the medical curriculum, we're saying, come, do a training of trainers and go back and teach these subjects, because that is the only way. One, the attitude is going to change, saying, no, it is part of healthcare. It is not an outlier that we call in only when nothing more we can do. So it's long-term advocacy. And part of the reason why I think these courses and these conversations that we're having today are so important is because every single one of us who's entering palliative care or is in palliative care, whether you like it or not, you are an advocate now.
Yeah.
You are an advocate now, and you have to go and advocate for this. So, long answer to a very crisp question, but it is that we have a huge amount of work ahead of us, and it has to come from within. And I will also, again, I do not want to offend anybody. This is also, I mean, this is a reality in some healthcare systems where palliative care is not a profitable business. No hospital is making tons of money on palliative care. There are no extended ICU admissions. There is no life support. There is no, expensive surgeries. So there's no profit to be made in palliative care. So why would a system that profits off suffering give that up? So we have our work cut out for us. Unfortunately, it's been an uphill battle for a long time, but not to say that it's all doom and gloom. We have made advancements because of this constant advocacy. The Narcotic Drugs and Psychotropic Substances Act has been amended, which I'm going to talk to you about. We have a national program for palliative care, which needs to be implemented. So each of you in your own states actually has the capacity to at least take this up to your state government level. And you'll find that there will be people who are amenable to this. It's just that palliative care has not been known. So, so yeah, lots of, we can do some of this work together. And I hope that by the end of the series, we'll figure out ways in which we can do that better. So,
Ma'am,
yeah.
there are a few questions and comments in the chat.
Yeah, all right. What if some patient is in a coma? How come being a palliative care caregiver can give that patient emotional, spiritual support? Okay. If I understand the question correctly, if a patient is in a coma or is in a vegetative state, how can a caregiver give that patient emotional and spiritual support? See, I'm not a neurologist, so I cannot tell you the medical, nuances of this. I do know that there's the AVPU scale, like people who are responsive to audio or auditory stimulus, people who are responsive to visual stimulus, pain, and people who are just not responsive. You will, I hope, have some time to interface with Dr. Roop Gursahani, who, like I said, worked on that seminal Aruna Shanbag case. So he's the right person to talk to about what a person is able to respond to and sense. But I think in the absence of knowing what the patient can go through, there is evidence to show that a lot of these patients still can hear. So talking to them, playing music for them, not behaving like they're not there, but actually, even in our, and Senia and Rajika, you can sort of back me up on this. Even in our unit, when somebody's unconscious, our nurses and doctors will always speak with the patient before they give them an injection or like when they approach them. And it's like the off chance that this person can hear you. And they might just be able to do that. The other thing is that, yeah, we maintain that thing of, making sure there are no bed sores. We're making sure that there is some movement, there's no pressure sores building up, things like that. And I think the medical doctors will be able to tell you how to assess and gauge whether what you're doing is working or not. But I will also say that a huge part of the emotional support is needed by the caregiver, because the human mind can be a very imaginative place also. So very often there's a lot of, caregivers might be really stressed out and burnt out and overthinking a situation or feeling guilty about something or whatever else. And I think at a time like that, when the patient for all practical purposes seems comfortable, it's the caregiver who really needs the care at that point. So that would be my take on it. What can we do in a situation where we cannot give solutions to any of their pain? We can do a lot. There are some kinds of pain that are not responsive to opioids. More and more methadone is being used as a pain relief measure, but a lot of people are not trained in it. In fact, we have a helpline which even doctors can access if they want tips on how to use methadone for pain relief where morphine is not working. But there are also non-pharmacological ways of reducing pain. I would also say, Sarah, that it's very rare that there is absolutely nothing that you can do. Even sitting with someone and talking to them, letting them tell you about what is bothering them is a way of reducing their pain, their emotional pain, their spiritual pain. Please understand, spiritual pain is also something. So I would say I have never in the last 18 years come across a case where, yes, sure, there are very challenging cases. There are cases where the patient is very difficult or resistant or non-compliant. But I'd say there's always something that can be done. Okay. We can give patients family support, but not to. Mona, I haven't understood that question. I'm sorry. Rachel, you can please check with the community engagement team, for that message that you sent me. Okay. Frequently we hear patients on ventilator, and it's really tough decision to ask the doctor to remove ventilator. How can we help patient family to consent? That is most difficult to take when removal of ventilator will end the life of the beloved. Okay, Mona. So you have a session on advanced care planning coming up in the series, and that is where we have the conversations on how getting a patient, a family to make a decision like that at an emotionally volatile time is very difficult. Which is why, as of February this year, the Supreme Court of India has recognized the living will as a legal document. It had already done that in 2018, but it had laid down some very, harrowing procedures if you wanted to get your advance directive upheld in a hospital. A lot of those barriers have been taken off now, and there are safeguards for the doctors. So a lot of doctors are scared to withhold or withdraw life support because they feel that there will be backlash later. But there are systems in place. There are ICMR guidelines for doctors and hospital administrators. Please look it up. There's the Blue Maple End of Life Protocol that is there, that Manipal has come up with. So we're happy to, Senior, please make a note of this. I will send this as part of the learning material. So all of these things are there, these resources are there. So there is some amount of protection, there is legal protection, and at the same time, the path is clear. Now, the important thing is you and I, as regular people, how comfortable are we talking about death and dying on a regular day? Try going home now and bringing this topic up with the rest of your family at dinner time. How many of you are going to be received well? And if some of you say, yeah, it's very easy to have that conversation, congratulations. I'm very happy to hear that. But but how many people, are you able to sit around with your elderly parents and maybe your child, teenage child, and say, hey, let's talk about, what would you like to do if I was seriously sick? Senior, how would that conversation go in your family?
Very bad, I think.
What is likely to be said back to you?
Right now, actually, my mom was a CA breast patient. So we used to have such conversations. She was always afraid of her girl children, both of us. So what's going to happen if she is going to death? She was really afraid of that. She's all right now, and till now she's not ready to think about her death or living will or anything else, I think.
Thank you for sharing that. I know that's not an easy thing to share, Senior. But she's made a point. Even when you've had a brush with serious illness, we still don't want to talk about it. The D word is taboo. For a lot of families, it's like, oh, apshagun, it's not something we should ever talk about because then we invite some sort of bad omen or something. So there's a saying, it's always too early until it's too late. It's always too early to talk about it till it's too late. And then then you have to make these decisions in a heightened, volatile environment where doctors are scared that the family is going to come back with some legal action, or the families are thinking that they're not doing enough, or whatever else it might be. Again, conversations to be had when we're healthy. Again, not an easy solution, but we need to start having these conversations amongst ourselves, at least with one another. What does a good death look like for you? Here's a question I'm asking you right now. And we're going to spend a little bit of time on this before I move on. What does a good death look like for yourself, for you?
I think probably like when I'll be asleep and then just don't get up from the sleep. Like that's it. I think as a child, we used to talk about like, oh, I don't want to die in a fire, or I don't want to die drowning. But I think that's about it.
Yeah. Okay, so let me narrow this down. Thanks, Vivek. How many of you want to die in a hospital? Hands up. How many of you would prefer to die at home? Yeah? How many of you would prefer to die at home than in the hospital? Okay, great. How many of you would, I mean, we know most of us would like to die in our sleep and go suddenly with no real pain, burden to our family, but how many of you want every extraordinary measure to save your life, no matter how many ICU visits, at whatever cost to the family? How many of you would want that sort of a, prolonged sort of, okay. Depends on the cause of death. Hospital, if that's demanded for the right treatment. Thank you, Anamika, for that. But I'm saying, I'm not really, again, let's not get cognitive about it. I'm going to talk about it from right now in the state that you're in. Would you prefer home or hospital? That was the question. Of course, in some cases, a hospital visit is needed, especially if somebody is dying at home and it's very, very difficult to manage the distress of that person and the family. In that case, maybe going to a hospital. But again, that hospital has to understand that you're not going to do CPR and ventilate and all of those things. The person finally has a cardiac arrest and dies. So, okay. It's hard to explain to someone who is dealing with it for the first time. I've seen prolonged death up close and know how horrible the thing is. Thanks, Lakshana, for sharing that. Yeah, we need to accept when we need to let go. Now, again, when do we let go? Different members in the family might have a different opinion about it. Somebody who is in a foreign country, is in the US, sending money for medical treatment and is not doing the day-to-day caregiving, might have a very different perception than the person who is doing the day-to-day caregiving. Yeah. Okay. So anyway, these are conversations that we need to have, and these are conversations that we will have over the next few series of modules that we have. Anyway, in the interest of time, I'm just going to come back to the slides. So we've talked about palliative care, what it is, why it's important, where does it fit in, what are some of the challenges, why is it that it's not available to everybody? Now, one important part of palliative care is access to medicines, okay? And access to medicines that are controversial medicines like morphine and other opioids. When I say the word morphine, I mean, I'm not asking people who are well in tune with opioids and morphine and palliative care. I'm just asking generally, what is the first thought that comes to your mind when someone says opioids? Let's not even say morphine, opioids. What's the first thought? Addiction, abuse, drugs, Afghanistan and Myanmar. Yep. Every single one of you who has used the chat box today has used the war on drugs rhetoric, by the way, which is the war on drugs rhetoric, which is, it's a bad thing. You know, drugs are bad. They need to be controlled. They need to be regulated. They need to be restricted. They do. Not bad, but they have to be used carefully. Now, We will do a session. I don't know if we're going to be doing, we can do a special session on the story of the NDPS, but I'm just going to take you through, why there's a need to, again, understand this subject a little bit better. Now, first of all decisions about access to medicines are made in global north countries. And here's the saying, if you're not at the table, you're on the menu. So very often we are not at the table of where the decisions are made. And by we, I mean India and other low and middle income countries. Decisions about healthcare are taken in Geneva. Decisions about access to medicines are taken in Vienna and New York. Most LMICs, not India maybe, but most LMICs do not even have diplomatic missions in these places. And yet the decisions made here have the highest impact on low and middle income countries. So you remember that quality of death index, and I told you that majority of the countries in the lower half were all low and middle income countries. Yeah. So classic example, if you're not at the table, you're on the menu. We've been on the menu for a very long time. And then decisions are, and people who do get to go to these conferences and things like that are people who are chosen and sponsored. Very often in alignment with what the larger, narrative is. Okay. Now, what kind of world map is this? The 2017 Lancet Commission on Global Access to Pain Relief and Palliative Care did this study on how accessible morphine and other opioids. So we call it the morphine consumption, morphine equivalent. So if you take all the opioids, morphine, fentanyl, and other preparations and things like that, there's a calculation we use to say the morphine equivalent consumption. So as per consumption of morphine, this is what the world map would look like if you go by proportionate use to need. India, only 4% of the need is met. So the percentage that you see in brackets is the percentage of need met. USA has a 3,150% need met. Australia has 1,890% of its need met. Western Europe also 870%. Look at countries like India, Uganda, all the low and middle income countries. Also, please know that, we will, if you look at it, India is also the only country in the world where opioids come under doesn't come under the Ministry of Health, it comes under the Ministry of Finance, under the Department of Revenue, because it's a hangover from the opium trade of the East India Company when it's a trade commodity. So decisions about morphine and pain relief medicines are being made by the Department of Revenue. I just sit with that for a little bit, okay? So any law that comes out is also coming out from that perspective. And in the 60s, 70s, and 80s, the US declared this big war on drugs. For very political reasons, I won't get into it. I feel very strongly about this topic. But as a result, and that and the international treaties, which is the drug conventions, several countries, including India, went and created laws for themselves to control and restrict access to drugs, and in India, it's the NDPS, Narcotic Drugs and Psychotropic Substances, probably made most famous last year by Aryan Khan and a bunch of other people. People who hadn't even heard about the NDPS suddenly knew all about the NDPS last year, but heard about it in the worst way. Yes, it is a highly restrictive law. And what the NDPS really did is that ever since, and this is another statistic, 75% of the world remains without access to proper pain relief. Asia's morphine per capita consumption is 36 times less than the global average. Asia, okay? We have some of the highest disease burden in the world. Now, consumption of morphine after the introduction of Narcotic Drugs and Psychotropic Substances Act fell by 97% between 1985 and 1997. That means that the pain burden of the country went up that much. So in a bid to control and restrict access to opioids, and first of all, the NDPS is a very convoluted law. This is what happened. We inflicted more pain on our own people. And India, by the way, is one of the largest manufacturers of morphine sulfate and the raw material used to make opioids. In the world, less than 4% of our people have access to it. And what the 1961 Single Convention, which defines all the laws about drugs and trafficking and drug reform, drug policy and things like that, it actually says very clearly that we have a dual responsibility to prevent the abuse of drugs and to make opioids available for those in pain. And actually it just says is that we must prevent misuse and diversion, but at the same time, we must make these drugs available for medical and scientific purposes. That's the actual language. I've just sort of changed it, rephrased it for this presentation. And so what does this principle of balance look like? The principle of balance says that, yes, we have to prevent misuse and diversion and illicit use. And that is determined by international laws of criminal justice. But we also have to make sure that as per human rights laws, people have access to this medicine. Unfortunately, the whole balance is tilted towards control, towards prevention, not towards access. And this is what drives this huge pain crisis that low and middle income countries have. We only hear about the US opioid crisis. And let me tell you, that is not a crisis of morphine. It is a crisis of street fentanyl. It's a whole other, that's a whole other thing. But that opioid crisis in a small region has defined and created another pain crisis in huge parts of the world. And this is a sad thing that this man with cancer pain spent most of 3 weeks in this position. 3 weeks in this position because he was in so much pain. And all it took was one tablet costing 3 rupees to get him to sit up and have a cup of tea for the first time in 3 weeks. 3 rupees worth of tablet. And this is the kind of thing that we're denying people, the ability to sit up and just, have a human experience. Now, a good health system delivers quality services to all people when and where they need them. This is what we talked about in the universal health coverage thing. But how are we to do that without having access to medicines? Sure, the law makes it available, but it is not accessible because we have to jump through all these hoops in order to have medicine available for the people who need it the most. We were part of the whole drive to change, bring in amendments to the NDPS Act, and it took us 19 years. So Mansi, just to remind you again that we are in a marathon and not in a sprint. And I'm really glad that more and more people are coming on board so that, there are more people running this marathon. What we really need is we need to think about policy and we need to think about education, what Mansi and I were talking about. We need to talk about demand, where all of us need to talk to our own communities. And, and the fact is we can work with policy change, we can work with legislation change, we can work with education of professionals and stuff. But we need people to get involved in the movement. We need the community to be involved, not just for advocacy, but also for service delivery. And we need to hear the voices of people with lived experience, the people who actually have that experience of what it means to have this illness or to be a caregiver. What are the actual needs, rather than somebody sitting, in corridors of power deciding what is most appropriate for someone with a serious illness. And what we really need is a large tent where from the local, national and international level, all of us need to come together and change the perception of palliative care, which is a very, very tall order. So I'm going to, I know we just have 1 minute, but I'm going to play you a video where I think, to me, this really encapsulates what real palliative care is. And this was a video that was made by the African Palliative Care Association, an absolutely fantastic association. So please indulge me for just a minute, and I'm gonna, pull that video up for you. Between the Western approach to palliative care and a low and middle income country approach to palliative care, the work for us is a lot more, because disease-specific treatment does not reach people in time or adequately enough. And when it does, sometimes it's not affordable. So for those of you who are already part of palliative care organizations, thank you all for the work you do. For those of you who are curious about palliative care and are now joining us, welcome. And I hope you will find meaning in the work that we're going to be doing together. So thank you for your time on this Friday afternoon. Have a great weekend. And I'm looking forward to getting to know more about your work and all of you. So Senia and Rajika, thanks very much.
Thank you so much, ma'am. And also thank you to all those who have joined for the session today. There will be a feedback form that will be available to you in your chat box as well as in your WhatsApp group. So please kindly use the form. Thank you all. Thank you.
Thank you all for joining today. We'll see you on the next session. Bye.
Thank you, ma'am.
Thank you, Smriti and Kelly.